Hello and welcome to our live stream. We're here with Dr. George DeVries, a foot and ankle surgeon with orthopedics and sports medicine BayCare Clinic in Manitowoc. Hello, doctor, and thanks for joining us today.
Hey, thanks a lot, Femi. I'm happy to be here. I look forward to this.
Great, great. Dr. DeVries will discuss all you need to know about total ankle replacement surgery. That's also known as a total ankle arthroplasty. First, let's learn a little bit about Dr. DeVries. He is board certified in foot, ankle, and rear foot surgery by the American Board of Foot and Ankle Surgery. He's also fellowship trained in foot and ankle reconstructive surgery. So before we get started, we want to invite you, our viewers, to ask any ankle-related questions in the comments section. We'll do our best to answer your questions in real time. If we do not get to your questions during the span of our broadcast, don't fret. We'll respond online soon after our live broadcast ends. So let's get right into it. Dr. DeVries, what is total ankle replacement surgery?
Well, I mean, just like the name implies, what we're doing is taking someone's ankle, their natural bone, cartilage, etc., and taking it out and replacing it with something new. Now, generally, this is not for a nice, normal-looking and working ankle joint, but something that's going to be arthritic, painful, causing people irritation. What we're doing is we're taking out and replacing the entire thing with metal and plastic.
Okay. Well, what are some of the symptoms that signal for you that a patient needs total ankle replacement surgery?
Sure. There's a couple of things that we look at. First, we'll kind of start with what I see. People will come in, they'll have significant amounts of swelling, pain. They'll feel some grinding and stuff when they're walking around. They'll have a difficult time doing the things that they wanted to. Usually they'll hurt with weather changes, stuff like that. We'll see x-rays almost always where we'll evaluate to look at what the joint looks like. Generally speaking, with an ankle that is a candidate for an ankle replacement, there'll be a loss of the joint space or the smooth cartilage that rides between the bones, which makes it painful. The bone can be sclerotic, or there'll be cyst formations, spurs, just various different findings that we'll see indicating that there's an arthritic ankle. Yeah, and people are just complaining about not being able to do the things that they wanted to.
Sure, sure. That just sounds painful. So describe your average total ankle replacement surgery patient. Is this person young, elderly? I mean, describe that person for us.
Sure, I would say average is kind of difficult to ascertain because each person is different, but I do tell people that there's an ideal patient that I have.
Okay.
55 and older is what I would recommend, and the reason being, although we are trying to make things better here, it's not skin and living tissue, so these things do wear out eventually. Usually takes, the best research that we have shows that about 90% will last at least 10 years. So they don't wear out quickly, but they do have a lifespan, and there's nothing to be able to regenerate them. Second is people that are a little bit on the lighter side. So I'd say people at 250 pounds and less is kind of the ideal that we're looking at it again. What we have is we have this metal component sitting on a piece of bone. So there is some pretty significant forces that'll be driving through the tibia and the tail sets, the bones of the ankle. Three, someone that is not going to be doing any active or impact sports. So people that like to run triathlons or do triple jump or maybe even going up and down ladders all day is not ideal. I tell people that golf is kind of my ideal sport, something you can walk around in. You can do the activity that you like. You can even walk the course here, but it's not going to be a lot of impact. Beyond that, medical history and deformity are the other things that we'll look at.
Okay. All right. Well, how often are you seeing and treating patients with ankle issues that actually require replacement surgery?
Far less than patients think. So I have a lot of times people will come in and say, "Hey, I just want my ankle replaced," and they'll be, 35 years old with an unstable ankle, or they'll have a little chip or a piece of cartilage that's loose or a spur. Most often with ankle pain, we can do a whole lot better than ankle replacement if we can get something back to the patient's own tissue and just get rid of some of the pathology, something that's going to be live and healthy and viable and can respond well to the stresses that the body has, certainly. That being said, it is a common thing most often after trauma or injury. So number one cause of ankle replacement is usually some type of injury, as opposed to knees and hips where they tend to just kind of wear out. An ankle usually will last unless there's something that's done to it, whether it's a fracture or a sprain, or very often a number of different sprains is different.
Okay. So we have an image coming up shortly. Oh, there it is. Okay. So here's an X-ray of a problematic ankle. I'm not trained in reading X-ray, so can you help us, and our viewers, describe for us what's going on here?
Sure. So the first thing that when I look at this is I'll actually look at the foot first, and the foot in this particular case actually lines up pretty well. Kind of right in the center of that, there's this oblong-looking bone that's called the talus, and it lines up pretty well with the front of the foot. So anytime we're looking at an ankle replacement or any ankle issues at all, we need to make sure that the foot is reasonable, because that's going to be the foundation or the base of anything that we do. After that, we're going to see a number of different issues. First of all, there's a lot of spurring and bone formation. What that does, it makes it very painful or even impossible for a patient to bring their foot up. So trying to walk up a hill or really step up it's going to be very difficult, because the foot just does not move up, because you'll get this bone-on-bone impingement.
Sure.
And then the last thing we see is that thick, that bright white line right in the middle, that should be black. What that indicates is, instead of having cartilage or the smooth gliding surface that we would normally have in between that area, that is what we'd call bone-on-bone or end-stage arthritis. And you're just grinding these two raw pieces of bone against each other, and that is very painful.
Yeah. Okay. So that's before surgery, and then we actually have an image post-surgery. So talk a little bit about what we're seeing here and how this differs from the image we just saw.
Sure. And again, what we're seeing, the foot is lining up very well. The heel's where it's supposed to be. So things underneath look good. But now, instead of having that large piece of bone in front of the ankle, that has been removed. So now the foot can freely move up and down without having any impingement. That black space between the two white pieces, those white pieces are metal components. Those metal ends are kind of capping off the bone on the top and the bottom. And then that black space in between, instead of cartilage, we put a piece of plastic in that area. So that represents the articulating or the smooth gliding surface that we replace the cartilage with.
And the pain experienced in the last X-ray, that's all gone at this point.
Yeah, and we tell people that these are actually very high patient satisfaction, because generally speaking, patients that need a replacement do come in with the X-rays like we saw at that last image.
Yeah.
And that is very painful with every single step that they take. Now, instead of having this grinding bone, you have nice capped off ends that have a smooth surface. And it's amazing to me sometimes how little patients will have pain. And the reality is that their normal threshold, their day-to-day pain is so severe that even the pain from surgery can be quite a bit less than what they're used to just on a day-to-day basis.
Okay. All right. Well, thanks again, Doctor. If you're just joining us, we're here with Dr. Jason George DeVries, a foot and ankle surgeon with orthopedics and sports medicine BayCare Clinic in Manitowoc. Remember, viewers, ask any ankle-related questions in the comments section. We'll do our best to answer your questions in real time. Doctor, it seems like ankle conditions are common among your patients. How do you diagnose ankle conditions?
Well, family, they are very common, because that is all I do. I do foot and ankle surgery and conditions, and that is it. So how do we diagnose this? Just like we talked about, first thing we do is talk to the patients. And that's why I always tell people, like, I may have background from an emergency room or from a primary care doc, but the first thing, and probably the most important thing that I do, is I get information from the patient. So I make sure that they explain to me what's going on. And a lot of times you can tell early on what the condition is going to be. Second is I evaluate people. So I'll try to figure out exactly where they're having painful. Sometimes it's difficult to tell exactly where you have pain. If your foot hurts, your toe hurts, your ankle hurts, it's difficult to sometimes pinpoint down. So I'll spend a long time trying to find out exactly where the issues are. And then most commonly, we'll also get X-rays. So that's kind of my three specific ways that we'll sit down and try to come up with a plan. And once we have those three experiences or those three data points all put together, we'll try to formulate a diagnosis, then move forward with the plan as well. Okay.
And then when an ankle condition is diagnosed and you find that surgery is going to be the best treatment, how do you determine the ideal surgical treatment option? For example, there's the ankle fusion procedure versus like an ankle replacement. How do you determine what will be best for the patient?
Sure. That's a complicated question, and that's what's different for each different patient. So what I tell people is there's two basic procedures that we do, either joint restoration, where we will fix the ankle that they have by removing cartilage issues or spurs or repair ligaments along the outside, or joint destructive, and that's where we either fuse it together or replace it. And that's a conversation I have with every single ankle replacement patient that we have. I tell people that both options, either an ankle fusion or an ankle replacement, are equal as far as we can tell for pain relief. If you have a painful ankle, this will help you. Where the things get different, ankle fusion is where we actually screw the two bones together. And if you kind of think about how much motion your ankle does on a day-to-day basis, every step that you're taking, screwing that together and losing about 70% of that motion overall is going to be detrimental. So people will have a bit of a stunted gait. They won't be able to walk quite as quickly. They may have a limp or a shorter stride, but it will last forever. So sometimes in younger patients, we may opt for that just because they have a lot of years, a lot of hard years on it. An ankle fusion, once done properly, should be able to last. The problem is it's also very hard on the joints around it. And that's where we'll talk about an ankle replacement. Ankle replacements just make a lot more sense. If you have a sore knee, a sore hip, you won't want to screw it together. You don't want to keep that motion there. An ankle replacement is good because it'll allow for more natural motion. There's tons and tons of studies that show that it works better than an ankle fusion, although still not exactly the same as a normal ankle. So what I tell people is I can give you a lot better motion than you had, a lot better function than you had, but this will not be a normal ankle. And again, the big downsides, and you and I talked about this already, is that they do wear out.
Right.
Again, properly placed and put well, and a patient that is doing the things that they're supposed to do, they should last, again, 90% are going to last at least 10 years, and we just simply do not have the longer term data out from that. We don't have data from 30 years of these things to figure out exactly how long they last. It's rapidly evolving. But those are the conversations we have when trying to choose which one is going to be best for the patient. All things considered, my preference is an ankle replacement. I think it does do a more functional and a higher satisfaction outcome that we have. But I would say in my practice, I'm about 50-50. There's enough people that have enough reasons not to replace it that an ankle fusion still is a very common procedure in my practice.
Sure. Okay. All right. Well, kind of talk us through, without getting too bogged down in the details, but what happens during ankle replacement surgery?
Yeah, so actually, it's pretty easy to not get bogged down because it's theoretically pretty simple. And technically, there are some details, right? But what we do is we go right through the front of the ankle, right where it moves up and down, and there'll be an incision there, and we'll get down into the ankle. And what I tell people is we basically take a block of the bad ankle and pull it out, and we'll reinstall these three components into there. Again, there's a metal end that'll cap the tibia, that's the shin bone, and a metal end that'll cap the talus, that's the top of the foot bone, and then a little plastic piece fits in there. So they come right in and out of the right out of the front of the ankle. They slide it out and basically fill that area right in with an ankle replacement.
All right, that's a great explanation. Thank you for that.
Not too detailed, right?
No, there you go. Perfect. So then, what are some non-surgical options for treating painful ankle conditions?
Yeah, and an ankle replacement, ankle arthritis in particular, has very specific things. So we'll do the simple things, right? Making sure that we're modifying our activity, using anti-inflammatories, icing it when it swells up, and continuing to move it. Sometimes people will shy away from moving it a little bit just because it hurts a lot of times, but that can make it very stiff and irritated. And that's the stuff that you should do before you come see me. When you see me, we'll talk about a couple different things. First is the support around the ankle. So we look at the types of shoes that people are wearing, make sure that they're cushioned. Sometimes we'll do a rocker bottom type of shoe as well. We'll try to immobilize, so while the ankle is walking and stuff and it's allowed to move, we don't want to have too much motion because that's painful, and that'll be with an ankle brace. There's a couple different braces out there, from a very simple lace-up ankle brace you'll see kids playing basketball with, to one with some hinges along the side, even to some custom braces occasionally. After that, physical therapy, I tell people it depends a little bit on where exactly they are. If they're having issues with stiffness or with instability, absolutely physical therapy. If not, not always. Probably one of the biggest things we'll do is an injection. And what I tell people is this is not curative. It's not going to heal you. However, it can give you a good amount of relief. Always temporary, but temporary maybe 9 months or so. So where I really push this is people come in, they say, hey, my daughter's getting married. Great, then we'll try to give you some temporary relief and kind of move from there.
Right.
If we find, however, that these options are not working, or they're not working well, or they're not working very long, that's when we start transitioning the conversation from something that we can deal with conservatively into more of a surgical option.
Okay. Okay. So what are some of the more common questions that you found that patients ask you when deciding whether or not to undergo ankle replacement surgery?
Sure, I'd say probably the biggest question and concern I have is, well, how much motion will I have afterward? And that's people's biggest concern with an ankle fusion. So I've had an ankle my whole life. It's supposed to move. It was put here together with an ankle that moved. How's it going to affect me afterward? So that's major concern afterward with how much motion. And what I tell people is, with an ankle replacement, the best predictor for how much motion you'll have afterward is how much you have beforehand, because there are some significant fibrosis and scarring that can happen even before an ankle replacement that can cause quite a bit of limitation motion. Now we'll get some of it back. We may do some lengthenings across tendons and stuff around that area, but the motion is afterwards generally predicted very well by what you had before. So I like to treat people for this if they have a lot of motion in their ankle. If it's already locked up, an ankle fusion may be an option. The next biggest question is, what do I got to, how do I change my life here? If they're very active, they're worried about, hey, will I not be able to do the things I want? What I tell people is anything you can do now, most often you can do better after an ankle replacement. Again, you don't have a lot of people with very arthritic ankles that are running triathlons or doing some of these high impact activities. So an ankle replacement generally will make walking, biking, swimming, elliptical better. People can play golf. People can get out and play with their kids or play with their dog and stuff like that. Those would be options. And the things you'd want to avoid were jumping or impact things. Being careful not to, really go out of their way and say walk on very uneven ground without a brace or something like that. Because again, the replacement is good, but it's not a normal ankle. So there are going to be some limitations with that. And the last option is probably how much pain we're going to have. What I tell people is, look, we're going to plan for the worst, and we'll make sure that you have adequate pain medication. We'll make sure we take care of you. Sometimes you'll spend a night in the hospital, but we're going to hope for the best, because very often, although it's a major operation, the amount of pain that people have before surgery can be pretty profound, and I think they just kind of lose track of how painful it is actually every day.
Okay. So, well, what do you tell patients to calm any concerns that they may have regarding ankle surgery? Go ahead.
Yeah. So what we do for that is these are big operations for patients. They are life changing, and they're patients that I plan to see for as long as they're around. So you will see me once, and we'll talk about the options. We'll talk about what is the best option for them. Most often, there's some type of advanced imaging, such as an MRI, or more often a CT scan. They'll see me again after the CT scan. We'll kind of run through the details. We'll answer any more questions. We'll figure where things are. And then they'll see me one more time yet, because most often the way I'll do this now is do this basically with a virtual surgery ahead of time. We'll plan out the implant, plan out the size, plan out the cuts, and actually have a custom made cut guide so that we can perform that operation we perform virtually on the patient. So they'll see me again. So they'll see me for 3 times beforehand. And what I tell people is, go home and think about what questions you have.
Right.
I have a number of different printed out sheets. They'll talk about these things, write them down. We're going to get to know each other for a while. Then we're going to be seeing each other afterward as well.
Right. So we do have a question comment that came in. We're being asked, this person apparently has been told that they need an ankle fusion or replacement to relieve pain. This person, it sounds like they're active. Pickleball seems to be their sport of choice. Um, currently can only play for about an hour, but needs some kind of thought as to, I don't know, just needs a thought from you.
Yeah, absolutely. So
You could take that without, we're not trying to diagnose or offer, direct medical advice, but we can speak in generalities.
absolutely. And so, I mean, this is someone that's already dealing with an arthritic ankle, and you started right away. They said either an ankle replacement or a fusion will help their pain, and I would agree that both of those will work, and both of those will be beneficial. Pickleball is a pretty active sport, but at the same time, there's typically not a lot of impact with it. So certainly some running around and some side to side. But pickleball is one that, again, I guess looking at the level that they're going to be able to play,
Right.
that is okay. So can you play sports? The short answer is maybe, right? If you say, I'd like to get back into tackle football, no, you will not be able to do that. Will I be able to get back and do the steeplechase? No, that's not something you do.
Right.
Will I be able to jog? Not for long distances. I really don't like that. However, if you want to throw a ball around, if you want to go play golf, if you want to do some limited kind of low impact, maybe doubles tennis, certain pickleball and stuff like that. Yes, I mean, the idea behind a replacement over a fusion is we are trying to keep people active.
Right.
We would like them to do the things that they want to do within reason. So can you play sports? Maybe. It really depends on what you're looking to get to.
Well, it sounds like, and I'm glad you said this, that the key is within reason. So I appreciate you saying that. Yeah. Okay. Viewers, feel free to continue to ask your ankle-related questions in the comments section. We'll do our best to answer you in real time. If we run out of time, just watch for a response after our live broadcast ends. We thank you for that question. Okay, Dr. DeVries, here's another x-ray of a problematic ankle. Can you briefly tell us what the issue is in this case?
Well, so we're seeing a lot of the same things we talked about before. Loss of joint space, spurring that we see along both sides. What we see a little bit more with this, and again, it's difficult to tell, that long bone that's coming from the top, that's the tibia, the ankle joint is right underneath that. But the joint underneath that is also arthritic. Now, not as bad, but we see some spurring and stuff along the back side of it. Has a little bit of a narrower joint space overall. And that's one of the big things that we'll look at when evaluating people. Fusions or screwing together of a joint is very hard on all the joints around it because all that stress that used to go through one joint now has to go through another. And people run into that a lot of times with back surgery. The adage is they'll have a back fusion or something, and then years down the line, they may be looking at something else. Well, it's the exact same thing here within the ankle. Right. We know that if we were to screw together this particular joint, potential for the joint underneath the ankle to become problematic is pretty high. So while I talked about my ideal patient in the past, this is one of those options that I may fudge or skew one way or another. Because again, we know that if we're fusing an ankle, we're going to be looking for trouble and looking for another potential surgery even coming down the line at another joint. Once we start screwing together multiple joints, then the function really does start to change quite a bit.
Okay. And so we're going to look at the surgically replaced ankle. Here we go. So what's noteworthy here?
So this guy, I apologize. It should be. So this patient in particular had some other issues with some bone irritation and bone connection between the outside ankle bone as well. So what ended up happening is it was a pretty stiff ankle overall. In addition, like I said, I always order a CT scan and we do a virtual surgery ahead of time. There is a significant amount of bony cysts and breakdown of some of the bone underneath. Anytime you do a replacement, what needs to happen is that the metal and the bone need to interface well together in order to provide a good surface and something that's going to hold up. In this particular case, the bone at the end of the tibia or the shin bone was not very good. So you're going to see that this is quite a bit larger of an implant. It goes up into the leg a little bit more. It's also a flatter cut along the top. And what the reason we're doing that is to remove some of the cyst formation, which again, this is why I do quite a bit of workup ahead of time, because again, we do not want to find this stuff out in surgery. We want to know ahead of time as much as we possibly can. And this just kind of shows that there are options for it. Even bad ankles can be treated with this. The last implant that you showed is what we'd call a bone sparing. Some of that we're able to keep as much of the natural bone as possible, just to preserve as much anatomy as possible. This one is showing that even in cases where some of that anatomy may not be viable or healthy anymore, we can work around that as well.
Okay. All right. Well, thank you so much for sharing. Let's keep the conversation going. Is a hospital stay required with total ankle replacement surgery?
No is the short answer. So, and that changed this year. So Medicare does a lot of mandates for what we can do and how we have to treat patients. So in the past, Medicare required this to be an inpatient procedure. So you had to come in, you had to stay at least one night in the hospital for this to be a covered service. Actually, this year they flip-flopped completely. And not only is it not required, but it can't be done as an inpatient anymore. It's what we call an outpatient-only procedure.
Wow. Okay.
So we'll talk to patients ahead of time. I would say, for the most part, I still keep people overnight, one night in the hospital. And it's just because a lot of people are nervous. We can have a chance of physical therapy, antibiotics, make sure that the pain is controlled and stuff. But I'd say about 25-30% of my patients at this point will go home that same day. So again, the short answer is it's not required, but a lot of times we can do that just for patient convenience, comfort, concerns, things like that. But if we have all of our ducks in a row, this is certainly something that can be done as an outpatient.
Okay, good to know. Good to know. What's the downtime after ankle replacement surgery?
Yep. I tell people with the ankle replacement that you can't walk on it for about 2 weeks. And that's probably the most obnoxious or kind of difficult time for people to deal with, because they have to be home. You can walk on the other leg. In fact, I don't want people bed bound. But at the same time, I can't have them put pressure on the ankle for about 2 weeks.
Okay.
I'll see them back at 1 week, just to make sure things are going okay. At 2 weeks, the splint will come off, and we'll put people into a cast. The reason we put people into a cast is I still don't want a lot of motion around the ankle. That can be difficult on the incision, but I do allow people to walk at the 2-week mark. So 2 weeks they're in a cast. At 4 weeks, cast comes off, and we put people into a removable boot. And that's where people will start walking on it, start taking it off, get into the shower, getting the area wet, utilizing moisturizers, start regaining the motion across the area. That boot's for about a month. So if you're keeping track in your head, about 1 month with the splint and then the cast, 1 month walking in the boot. At 2 months, people are generally in an ankle brace, regular shoe. We start physical therapy to get them rehabilitated, get them back to the activity that they want. Sure. That takes about 2 months. So all said and done, I tell patients it's about a 4-month recovery, 2 months of rest, and then 2 months of rehabilitation.
Okay. Okay. And then once a patient gets the all clear from your office, any restrictions?
Yep. Avoid impact activity. Avoid all the things we've been kind of talking about over and over. Walking, great. Biking, swimming, elliptical, great. Low impact sports, great. That's why we're doing this for. And then I will plan to set up some visits for them afterward.
Okay. Is there typically any swelling or drainage or lingering pain after surgery? And if so, how do you monitor and address that?
Most often with an ankle replacement, I'll actually plan ahead to avoid any drainage. So I'd say about 75-80% of my procedures will put a dressing along the front of the ankle that will actually suck the fluid out of there. Okay, and the idea is we would like to not have a lot of fluid draining out of it. We don't want to have a lot of fluid building up underneath the incision as well. So while there may be drainage, it's expected and it's controlled. At the 2-week visit, we'll put a special absorptive dressing on there.
Right.
Will people have swelling? Absolutely. You're going to have pain, you're going to have swelling, you're going to have stiffness. That is exactly why we planned for a 4-month recovery instead of just 2. Because again, at 2 months, you're walking in regular shoes. But I always want patients to kind of understand that this is a normal part of the process.
Sure.
The issue with working on foot and ankle, which is what I do, is that gravity is always working against you. Okay, if you have a sore hand or something, there's ways to avoid it. If you have a sore foot, generally you have to walk on it. And even if you're not walking on it, very often it's down lower than your heart, and gravity is always working against us, always trying to have the area swell more. And that is a lingering thing, but it's expected. We have compression, we have physical therapy, occupational therapy. And that's why I tell people this is part of the recovery, not something abnormal and not something unexpected.
Okay. Well, and kind of going with the physical therapy. You mentioned that a couple of times. Is that a given with this kind of surgery, or is that like an optional thing?
I recommend it 100% of the time. So no, I'm not going to force someone to go there, but
Right.
it is an integral part of the recovery for me. These things are stiff and they can be swollen. Again, we have about a month where it can't really move at all in the splint and then the cast, and then a month where it's relatively immobilized in the boot. So what I tell people is, we've kind of set you up for physical therapy to have a lot of work to do. There are certainly people that don't, but I always recommend it 100% of the time. And I will tell you that most often people are very happy that they did it. There are things that physical therapy will do to really optimize the result. And if we're going to go through all the headache, hassle,
Yeah.
expense, risk of this, we want to get as good of outcome as possible.
Yeah. Well, let's kind of stick with that for a minute. So you recommend physical therapy for a patient. He or she maybe starts it and then misses an appointment here, misses an appointment there, and before you know of it, physical therapy is a thing of the past. Why is it important for people to follow through and complete physical therapy after this kind of surgical procedure?
Well, I mean, what I tell people is we're a team here, right? So I'm part of the team. Patients certainly part of the team. Physical therapy is part of the team, and we all have different roles to play,
Right.
and they're each an important role. The body really goes through a lot of trauma to have an arthritic ankle in the first place. There's a lot of scarring, irritation, chronic inflammation that people may have had for years even before that. And then surgery is a trauma as well. There's going to be some scarring, some irritation, some fibrosis where things are going to want to scar down across that area. Physical therapy is specifically helped and trained to make sure we can mobilize these tissues, get the scar healed as well as possible, make sure patients are not developing bad habits. Sometimes people will start walking funny because they're trying to compensate or avoid something, and physical therapy can recognize that early. If you recognize something early and fix it ahead of time, it generally won't become an issue, as opposed to just trying to kind of muscle through it or rub some dirt on it. And now we have issues that are there. We got to dig ourselves out of a hole a little bit more.
Okay. Okay. Let's talk a little bit about some of the hardware. Those images earlier were fascinating. I mean, what is this stuff made of? You said metal, plastic. I mean, talk a little bit about that.
Sure. The metal components are what we call a cobalt chromium metallic implant, and then there's a plasma spray, or basically some porous metal on the back sides. And the idea, the porous metal, or this metal with all these little holes in it, is to give something for the bone to grip into at first, and then ultimately grow into, so we can have a seamless integration of that metal and that bone.
Okay.
The plastic too is not, say, your typical plastic or PVC. It's what we call ultra high molecular weight polyethylene. Sometimes even infused with a vitamin E to keep things more mobile. The plastic piece is where a lot of the impact goes through, and some of the older implants had issues with it, where the metal would actually break through the plastic. So there's a lot of technology in this area to make sure that it's protected, make sure that it's going to last, make sure that it has the capacity to kind of absorb, say, 10,000 steps a day for many years.
Wow. Okay. And then for many years, how many years are we talking?
What I tell people is expect minimum of 10 years. But generally speaking, if we do an operation, our plan is to have this thing last as long as the patient would like to be using it. After the 10-year mark, we just don't have the data, and there are things that can be done to fix or kind of update it. What we tell people a lot of times is, if you're using a lot, that little plastic piece can wear down. Eventually it can start to either be brittle or get ground down a little bit, in which case we can do what we call a poly exchange. The poly is the plastic liner in there. Take that out and put a new one in there, and basically give us that support structure back. The other things we'll look for is there cyst formation? Is there spur formation? Is there anything else that we're looking for that could prevent this? So these are patients that, even if they're not having an issue, I like to see every year, just as a, how are you doing, and get an x-ray to figure out where things are. Because just like with therapy, you want to kind of jump on it early so there's not problems down the line. There are things that we can occasionally see that are easy to fix, right? Maybe we change activity, put it into a brace, give it an injection. Even surgically, sometimes we can do some augmentations or something much less invasive.
Right.
Try to give this ankle as much of a long-term expectancy as possible.
Okay. There was another question that came in when we were talking earlier about the activities that you could do after a patient gets the all clear from your office. So you talked about pickleball, maybe-ish, football, no. Um, so this person is asking, how about cross-country skiing?
Yeah, cross-country skiing would be great. So generally speaking, you have pretty good support across the boots. That's a lower impact activity, but it's also something that's going to require a lot of motion. So that's
Right.
another that's a great option because an ankle fusion is going to limit that, where an ankle replacement would be ideal for something.
Okay.
That's a great sport. Love to have people doing that. I kind of put that very similar to an elliptical.
Sure, sure. All right, excellent. Thanks for the information. If you're just joining us, we're here with Dr. Jason George DeVries, a foot and ankle surgeon with Orthopedics and Sports Medicine BayCare Clinic in Manitowoc. We're hosting this Q&A type session focused on total ankle replacement surgery. Doctor, too many of us often ignore ortho-related pain and discomfort or rely on home treatments, including painkillers, ice, or heat. Why is this ill-advised, especially if this pain condition, today we're talking about ankles, just doesn't go away?
Perfect. It's not ill-advised to try it. And in fact, I always make sure that people have tried that. But if it is not responding,
Right,
what can end up happening is you can continue to damage the area more and more. And what I tell people is that eventually bridges will get burned, right? So if you have an unstable ankle and you get some ankle sprains and you just continue to walk through it,
right,
what could have potentially gotten better with a brace therapy or even surgically repairing the ligaments, if it's out for long enough, now becomes arthritic and irritated. Now we're talking about ankle fusion or replacement. Similarly, with ankle fusion then replacement, we talked a little bit about my ideal candidates and how much deformity or how far out of position they are.
right,
As people progress, the conditions and the deformity can get worse. And there is a point that some of these options are not possible anymore. Either the bone quality is not good enough. So even with those larger implants, we'd no longer be able to remove enough of the bad bone, or the deformity or the position is so bad that it's no longer something that we would be able to realign and then have a safe, stable ankle to work on. Or the joint underneath it can become very arthritic. We showed that on that second case as well.
right,
If that becomes very arthritic, now that does need to be dealt with as well. And you're adding complexity, and eventually you'll lose some options. Early on, we'll have a lot of options, and as things go away,
right,
they can get fewer and fewer.
right. Okay. Well, but how do I know if my ankle issue is worth coming to see you?
Great. Number one question I ask is, how does this affect your life? And each person has a very different outlook and what they're looking to have. So I will have patients saying that, around mile 20 when I'm running, I have some foot or ankle pain. Okay, well, that's their problem. That would not be a problem for me. I'm not going to be doing that.
Right,
Some people have problems when they're just gardening or they like to play with their grandkids or walk their dog. When your foot or ankle is an issue to the point that you say, I would like to do something, but I either can't because it's too painful,
right,
or I don't enjoy it anymore because it's painful, or I just will avoid doing it, well, that's an issue. And the joke I tell people is I can make anyone's foot or ankle feel better by sticking them on the couch and making them a couch potato. But that's bad for everything else. Bad for life. It's bad for your heart. Bad for your lungs. Bad for your weight. We need to keep active on it. That's part of what we do. So when we have an ankle that starts to affect the things that you want to do and they no longer are able to be done, that's when I would come in and be seen.
okay. Well, what are some risk factors for ankle health issues?
The number one, well, not the number one, again, for an ankle replacement or ankle arthritis, it's a previous injury, whether it's an ankle sprain or ankle trauma. Those are the major risk factors. About 70% of ankle replacements will be preceded by some type of trauma ahead of time.
Okay.
Beyond that, it's looking at different past medical issues. Certainly, some of the systemic our arthritis issues, such as rheumatoid arthritis, psoriatic arthritis, are going to make you much more susceptible to this. Beyond that, it can be weight, diabetes, certain activities that you'd be doing. Some people are prone to having a flat foot. They've had it for a long time. That can put stress along it. But I would say that the number one issues that I run into first is trauma, and second is some type of systemic arthritis for this condition.
Okay. Can you offer a couple of tips on how best to keep our ankles healthy?
Listen to your body is probably the number one, right? So if you find that every time you're playing basketball, you're spraining your ankle, pay attention. That means that there's an issue with that, whether it's just a brace or athletic training or taping. Pay attention to it. If it hurts or is limiting what you're doing, your body generally will help you out. Now, the caveat, of course, is there are certain patients that don't have good feeling across the area. So be aware. If your ankle is much more swollen than the other side, if it's giving out, if it makes noises, some people actually hear a grinding in their ankle. Listen, your body does a pretty good job trying to tell you and trying to inform you that there's something going wrong with it.
Okay. All right. Great conversation, doctor. You're a board certified foot and ankle surgeon, and you've also had additional high-level education in the form of fellowship training. What does that mean for the level of care that patients can receive from you?
Sure. So my school was in, so I'm a podiatrist or a doctor of podiatric medicine. My school was to get that degree. I did a 3-year residency for podiatry, and that's generally it's either 2 or 3 years now, where we did all types of clinical and surgical foot and ankle care. Then after that, I did a fellowship in Columbus, Ohio, and that was an orthopedic fellowship. My 2 fellows, co-fellows, were an MD and a DO, and it was a mixed faculty with 1 DPM and 3 foot and ankle orthopedic surgeons.
Okay.
So what I would hope to do with that is I should provide a relatively large breadth of experience and kind of differing opinions. And there are differences in how each of these specialties kind of approach different conditions.
Right.
What I hope to do is kind of bring the 2 of those together to offer a real positive spin or an outlook from both sides that hopefully give patients a more holistic approach to how best to take care of their ankle.
Great answer. Thank you so much. A couple more questions for you. If patients are dealing with symptoms they think might be related to some of the ankle issues that we've discussed today, what should be their course of action?
You talked before about ice, anti-inflammatories, rest. Absolutely, that's the first line of defense. If it does not respond, come in, because having an evaluation, getting an X-ray, seeing what we have is really integral to get an idea what the patient has at this point, and also give some prognostication or looking forward to see what in the world they're going to end up with in the future. So if it is something that is just not going away or it's getting worse for sure, come in. I mean, that is the simplest advice I can give people.
Okay. Are referrals needed to see you at all?
Nope, no referrals needed. If your foot or ankle hurts, give our office a call. They'll shuttle you to one of the providers, most often for me for foot and ankle.
Right. Okay. Well, we've certainly covered a lot today, and I thank you for your time and sharing your knowledge. We're very grateful for that. And we thank you, viewers, for joining us. If you have additional questions for Dr. Jason George DeVries, please ask them in the comment section. We will continue to answer them online. As mentioned earlier, Dr. DeVries is a foot and ankle surgeon with orthopedics and sports medicine BayCare Clinic in Manitowoc. To learn more about Dr. DeVries and his medical experience and specialization, or to request an appointment, please visit baycare.net/ortho. We thank you so much and enjoy the rest of your day.
Thanks a lot, guys.